clinical pointers on managing extrapyramidal symptoms. So recognizing extrapyramidal symptoms can be challenging. As we discussed in the prior section, many of the symptoms can mimic idiopathic movement disorders such as essential tremor or Parkinson's disease. And many movement disorders are diagnosed clinically, meaning that there's no blood test or diagnostic biomarker. I mentioned that the DAT scan, dopamine transporter SPECT scan, is approved to help differentiate Parkinson's disease from essential tremor, but it does not yet carry an indication to differentiate drug-induced Parkinson's from other conditions at this time. That is something that we've been lobbying for, but hasn't happened yet. So it might be tricky to get DAT scan approved for this indication, but certainly it's been reported that it may be a helpful tool. So essentially, careful assessment of the symptoms and the time frame within which the medications that are thought to be causal is required in each case. So here are some pointers. Once you identify the extrapyramidal symptoms, you should start thinking about, can the treatment of the primary target be modified? And this will depend a lot on the clinical situation and the acuity of the illness. So can you reduce the dose of the agent without losing efficacy is usually a good place to start. So if the symptoms are well controlled, but you're having extrapyramidal symptoms, try gradual dose reduction. If that doesn't work, can you switch agents to something with a lower risk of causing extrapyramidal symptoms? So the most classic example of this is moving from a typical to an atypical antipsychotic. So the other thing to be aware of is, are the extrapyramidal symptoms of sufficient severity to impair function or cause distress in the patient? If not, this might just be something to monitor. If you have to use medications, anticholinergics are typically the first line. In younger populations, this is usually well tolerated. However, with chronic use, they may increase the risk of dementia and cause some cognitive impairment. And this is especially true when you use it in elderly populations. So prophylaxis with anticholinergics is not recommended due to these risks. Now, let's say you try anticholinergic medications and they fail. Amantadine may be helpful. This is a molecule with some pro-dopaminergic properties. It's also a little bit anticholinergic, and it might be helpful. In severe cases, electroconvulsive therapy is known to rapidly improve extrapyramidal symptoms. And in fact, it actually helps idiopathic Parkinson's disease as well. But again, obviously, this is not something that's sustainable for chronic treatment and carries some risks. Most drug-induced Parkinsonism is not responsive to dopamine replacement therapies such as levodopa or dopamine agonists, as I mentioned, with the possible exception of drug-induced Parkinsonism caused by drugs that deplete presynaptic dopamine, such as the VMAT2 inhibitors, your tetrabenazine and deuterated tetrabenazine, the second-generation ones. So what's the prognosis of drug-induced extrapyramidal symptoms once they're recognized? So they're generally considered to be reversible. In most cases, symptoms remit within 4 months with an upper range of 6 to 18 months. However, in about 15% of cases, especially those caused by antipsychotics, the Parkinsonism or extrapyramidal symptoms may persist. In these patients, sometimes it's not uncommon to find out this is early unrecognized Parkinson's, but sometimes, unfortunately, this can become a chronic side effect of these drugs. So the key points for this section are that excluding an idiopathic movement disorder from the differential diagnosis is an important first step in the treatment of extrapyramidal symptoms. Again, this is challenging. You can refer to a neurologist. And then, as I mentioned, there's some emerging technologies like dopamine transporter SPECT scanning that might be helpful. Avoid polypharmacy and side effects. You can try dose reduction and alternative drugs first before introducing drug to treat these symptoms. But if you can't improve the symptoms by dose reduction or alternative therapies, anticholinergic medications are first line, followed by amantadine. ECT is one of the most effective and rapidly acting treatments for EPS, but again, it might not be logistically feasible in many cases.